Welcome warriors. So in this video we are going to cover dyspepsia. Now for dyspepsia, it's a spectrum of symptoms. You have to think of it this way and you have to rule out other critical diagnoses before saying that the patient has functional dyspepsia. Even a pharmacist invented the Pepsi, the soda drink, to treat dyspepsia. It was that difficult. So once you see nausea, vomiting and epigastric discomfort or pain, think of dyspepsia. So you rule out other possibilities, then you say it's functional dyspepsia. Now first, we start with ruling out other possibilities or diagnoses. So once you have patient with these symptoms, you need to check up a screen for alarming symptoms. So we have the anemia, age more than 50 and risk factors, age more than 50 and risk factors, fecal occult blood test positive, melena, hematemesis, or vomiting. Although we mentioned vomiting in the initial symptoms, once you see vomiting, you need to do a scope to rule out gastric outlet obstruction or malignancy. It's not normal to have functional dyspepsia with vomiting. Now, then we screen the patient history to see if any medication is causing these symptoms, like NSAIDs, aspirin, potassium, bisphosphonate, and some antibiotics. Huge pills can irritate the gastric mucosa and cause gastritis. In this case, we need to make sure that the patient is not on any of these therapies, especially if the symptoms started after starting these medications. Also, the risk factors of this medication increase if the patient is on anticoagulation. On the day of your exam, if you see alarming symptoms, you do a scope. If you see any medication, then you tend to stop them to see if the patient symptoms will improve. Now, if you are facing a patient and you suspected dyspepsia and he has no alarming symptoms and no recent history of any of the previous medication, then you look at the patient age. If the patient age is more than 60, then you go with the scope. I know we said previously that the patient age is more than 50, we need to do a scope, but more than 50 needs risk factors like alcohol use or smoking history, then you go with a scope. Otherwise, you look at the patient, he has no alarming symptoms, no medication, more than 60, you do EGD. If he's less than 60, no alarming symptoms, no medications, then you need to rule out H. pylori. So less than 60, no alarming, no recent medication, we do with H. pylori. If it's positive, then we treat it. If it's negative, we do the next step is to give a trial of PPIs and to see if the patient will respond symptomatically to this treatment. If he responded, then we assume he has an acid oversecretion or he has a reflux, which is also GERD, gastroesophageal reflux disease. If he's still symptomatic despite the treatment, then we need to do an EGD to rule out malignancy. So in dyspepsia, if we have alarming symptoms, we have to rule out cancer. We do EGD. If we have no cancer, we review the medication. No medication, then we go to the next step. We look at the age. If the age is less than 60 years, then we go and rule out H. pylori. If it's positive, then we treat it. If it's negative, we give a trial of a PPI to make sure we are not missing a GERD. If the patient improved, then we say it's GERD. If it's not, then we need to do an EGD again. If the age is more than 60, then we go to do EGD to rule out malignancy. Now, we will cover gastroparesis. So, gastroparesis means a paralyzed stomach. So, we have delayed emptying of the stomach. All the conditions will lead to this stomach. So, we have systemic sclerosis, diabetes mellitus history in the patient, hypothyroidism, and some medications that has anticholinergic effect or like morphine. I want you to remember that we have change in structures. In systemic sclerosis, we lose the muscular layer, we have fibrous tissue instead, and this is the reason behind the slowing. In diabetes mellitus, we have the neuropathy, so it's a neuron issue. So first we have muscle issue, second we have a neuron issue. For the hypothyroidism, we have a metabolic issue, and for the morphine and anticholinergic, it's a medication effect causing the slowing emptying of the stomach. So let's jump to the symptoms. Once you see the history of these patients, you will see nausea, bloating, early satiety because the food will stuck in the stomach and we will cause this side effects. Some patients might do vomiting to relieve the pain or the discomfort more than pain. Always rule out gastric outlet obstruction in case you have weight loss, anemia, or the patient has alarming symptoms. And remember, once you have an acute obstruction of the stomach, remember to rule out gastric outlet obstruction, especially if the patient has a history of gastric cancer. So you do EGD to rule it out. If you have a recent viral infection, it can cause viral gastritis and cause also gastric emptying problem. So you see symptoms of gastroparesis, but you don't see the risk factor in the history. So in that case, you see a viral infection, recent viral infection. Think of this as a cause. Otherwise, for all the sudden obstructive symptoms, remember to do EGD and have cancer as a differential on your exam. Rule out cancer once you see any alarming symptoms. Again, anemia, weight loss, smoking history, history of gastric cancer, think of cancer again. For the diagnosis of gastric emptying, you need to do a special study. It is named under the gastric emptying studies. So we have two studies. We have the scintigraphy, which shows delayed emptying, and sometimes they might mention the other test, which is the carbon breath test. Also, this test will show a delay in the gastric emptying. Now, as a hint, these studies are done with the glucose is controlled, meaning less than 275, or if you want, less than 300, because hyperglycemia in itself, it causes decrease in gastric emptying. If you go back to physiology, you will find once the food reaches the intestine and increases the blood glucose, the stomach will receive signals from hormones to slow the gastric emptying to allow time for the food to be digested. Remember, you have to rule out cancer, and the treatment is to do diet modification, small multiple portions a day to let it go and pass the stomach. And we have other treatment to treat acute symptoms and chronic symptoms. For the chronic symptoms, we use PO medications. For the acute symptoms, we use IV medications because the patient is not able to, he can swallow the pills, but it won't pass. So we have the metoclopramide, and also we have the erythromycin. If given IV, the erythromycin will work on motilin receptors, which are responsible for the gastric motility and will increase the gastric emptying. Metoclopramide, this medication is antidopaminergic. It will hasten the emptying of the stomach, and it will help in such patients. Remember, sometimes they mention the gastroparesis case and they say we give the usual medication. They mean metoclopramide, or the patient was given a medication, and then they say that he has tardive dyskinesia, or they might mention that he has Parkinsonism. So remember metoclopramide as the cause. It can cause this as a side effect because of antidopaminergic effect. Remember this. And always don't forget to rule out malignancy in patients with alarming features or if they have acute symptoms. Sudden obstruction, remember to rule out malignancies. Now we reach the end of the video. Please subscribe and support the channel, and thank you for your time. Currently we are reviewing step 2 CK. We'll review step 1 later on. Good luck on your preparation. See you again.